Okay, it looks like we're kind of plateauing with the number of people engaged. So welcome everyone. I think it's been a month since we did our last town hall, or a year in COVID time. So a lot of things to talk about, and then to address your questions. So if we can start first with Dr. Thomas and kind of give an update in general about the situation at CMC and CRMC with COVID.
Thank you for having me. So just some general numbers here. CMC, our testing to date, 77,880 tests done. So we're moving up there. Our burn rate with our testing is about 350 tests per day, which gives us 62 days on hand. So from a depth in the bullpen, we got a lot of resources available for testing. Total positives in the system, 7,640 so far. As far as our census, and this number changes minute to minute, currently we have about 390 patients. That's down from 425 a week ago. That appeared to be our highest all-time number, was 425. ICU, looking at capacities, they fluctuate a bit based upon what's in the ED, and I'm sure Dr. Jane's going to talk about that a little bit later. But we're running essentially 98 to 110% of ICU capacity, depending on where people are downgraded and where they're sitting at the time. In our staff makeup, we've had 251 positives currently, and there's 322 people currently out on quarantine. I picked up an interesting statistic. Our total quarantine days to date for our staff have been 4,500, if you can believe that. 248 of those days were work-related, 375 were tied to home, but 4,100 were related to community sources. So people are not, as a percentage, getting infected as much or exposed as much at work as they are out in their other life, which makes it tough for us. PPEs looked good. Our supply chains are stable. We're always looking for new resources. We have done some refitting of folks, and we appreciate patience with that, because as we identify a new product line or provider in the supply chain, we can move people over to that particular mask. We did that with the 3M 9205 Plus recently. And as far as lab goes, we did get a new platform from the state called PerkinElmer. Gave us about 9,000 tests a month. That's 300 a day. So if for those of you that have been following our lab capacity, it jumped up to about 20,000 tests on the shelf. Unfortunately, it's not a rapid turnaround test, but if we're creative in how we batch those tests, we'll do well. We're still tracking things in the pharmacy as far as medications and shortages. The CCG has been very proactive in trying to look ahead and see what deficits we might experience. The vaccines, greater than 5,000 people have been vaccinated to date. We've only had a couple of reactions. One was quasi-anaphylactic, and that person was watched for a couple hours in the ER, but nothing significant. And from what we're hearing, the absenteeism, at least after the first dose, was not very high. We are reaching out. There are, I think, about 35 docs who have not scheduled their second, and we really want to get them scheduled. So if you can encourage your peers to be proactive about getting that second test scheduled. Some of the highlights as far as surge planning, as you know, there are no further elective cases going on within our hospitals, all of them. We are shifting patients about, moving ICU patients to heart from Clovis and CRMC. Nursing resources are being shifted. We certainly appreciate the assistance of some of the residents that I know voluntarily gave up electives and chose to serve in the ICU. That's helped us out. And we did get another Department of Defense team last week, 25 folks, including 4 docs. 2 of them became hospitalists out at Clovis because they had some pretty significant deficits out there, and 2 of them are working in the ICU here. Dr. Jane will probably talk about that. Talk just a minute about crisis standards of care. The state issued a requirement or a mandate that hospitals publicly post what they're going to do to ration care. Not that they're doing it, but they needed a plan that needed to be reviewed. We had a committee that met last spring, put together a great document that was approved by the Board of Trustees. I'll just say we're fine tuning that document right now. We've recruited a number of people to serve in that capacity, and God forbid we need to go there. I think that we're making the right strokes to make that happen, such that we can implement those and better protect our patients. Fortunately, as we've said, the prevalence is leveled off a little bit. And as far as clusters, we are perpetually addressing hospital outbreaks, doing contract tracing. We appreciate participation of folks in patient care. We've had to make some changes on retesting of inpatients, testing of patients with high suspicion, and that will continue to evolve as our numbers change. So I think that's all I have. I'd be happy to answer any questions now or at the end of the town hall.
Okay, good. Thanks, Jeff. Vipul, you want to move on and talk specifically about what's going on in the ICU with COVID?
Yes, I actually figured it would be easier if I put it on a slide. Give me just 1 second here. Is my screen up? Okay, great. Thanks, Tiffany, for the acknowledgement. The x-axis of what you're seeing is the timeline through this year, and the y-axis is the total number of patients in the ICU. As you can see, our pre-COVID ICU census runs about 30 patients, give or take. That's early part of the year before the surge hit us. With the summer surge, it exploded to highs in just above 50 or the low 50s range. We did get through it with 3 formal MICU teams that we had placed at the time, and also an additional non-admitting military team. The military folks at the time included an intensivist, and so he led that 4 team, and we were able to get through the summer surge. Now, based on that, we pre-planned our winter surge with the ability to launch a 4th surge team, kind of like in place of the military team, as needed, to handle little over 50 patients. But little did we know at the time that the summer surge was just a preview, and the real movie was to begin with the winter surge. So that brings us to November, where I think right after Thanksgiving, we started to see the surge numbers, and we had already crossed 50. We launched our 4th team right there because we were prepared for it. But unfortunately, the surge did keep going up, which we kind of got a good idea by early November that this was going to be much worse. I discussed with my group, and early December, everyone was geared up. We launched our 5th surge team, and this still continued to be challenging as we moved on. I was worried about burnout and an ability to sustain this structure for the weeks to come. Fortunately, as Jeff mentioned, as our core medicine ICU teams stayed frontline as the admitting teams, we were able to infuse help in our surge teams, which are non-admitting, that came in the form of ER and FP emergency medicine and family practice volunteer residents. So by end of December, however, not only was the census on the uptrend, but the turnover also got very high, to the point where at one point we had some days of call where we were getting an admission per hour, not to mention the high acuity. And right at that time, our military team came in. That help was very timely. That included 2 physicians, as Jeff mentioned. One's a preventive cardiologist, and the other one a hospitalist with some ICU background in terms of experience. And they very graciously integrated into our faculty-led search teams. Early Jan, we were able to also prepone the start date of one of our APPs that was supposed to start in January, and we got him emergent privileges through the hospital. So he started right in the early first week of Jan. So all of these key components that formed the teams helped us navigate through the surge so far. One of the instrumental aspects was the night coverage and the day procedure team that we were able to put in place with the help from anesthesia, really at very short notice, both to the hospital and the anesthesia teams. And all of these pieces really were parts of the train that we were moving through the surge, just planning day to day or week to week. But most importantly, I want to emphasize that one of the key reasons we have gotten this far so well is because of our trainees, who really drive this system. I do believe that thus far, despite the current surge, in overwhelming numbers, we have been able to deliver the care that a top-tier academic institution is expected to. And we couldn't do that if it weren't for our permanent critical care fellows and the MICU interns and residents, as well as all of the other house staff who have volunteered and contributed in us getting through this surge. So thank you very much. And I really mean that from the bottom of my heart. The last thing I will say is, while it's too early to take our guard off by any means, or even to predict in any reliable fashion what's coming up, the census does seem to have plateaued a little bit. We hit an absolute high of 80 on Jan 3rd, and then it's in the last few days it's kind of mellowed a little bit. This morning was 55. I haven't checked in the last couple hours, but we'll see what's coming up. We have a list of medicine volunteers ready to jump in if the surge was to uptick as and when. We have had faculty from other departments that have asked to jump in as we need. So we're going to continue our 5 teams and maintain the structure as it goes, and then take it by the day and by the week. So that's all I have.
So Vipul, I don't know if Jeff or you want to address this question. So one of the issues in terms of being able to take care of these patient volumes is clearly the physician aspect that you've touched on. What about nursing? How's the ICU nursing staffing going, and what limitations are there in terms of them?
So the nursing has a little bit of a different approach to what they're allowed to do. As we talk about crisis standards of care, we have had crisis ratios, which means that an ICU nurse who typically takes 2 patients can take 3 to 4 patients, and then under disaster circumstances, that number can go even higher. Vipul and I have been talking throughout the pandemic as things have surged about, team care. Nurses can employ a team care paradigm where maybe a more experienced ICU nurse has med-surg nurses that fall underneath. We have, as I've said, platoon resources from Fresno Heart, out to Clovis, down to CRMC. We've done some sleight of hand with our cardiac patients. As you know, some of those CVU patients require special nursing skills. So we're doing our best to maintain service lines and a continuum of ability to care for those cardiac patients at both Fresno Heart and CRMC. So it's a daily struggle. Twice a day we have capacity calls where we talk about shifting nursing resources. We did get some resources from the military and from the state of California. So we continue to work at it.
Great. Lori, do you want to weigh in at all about the conversations you've been having about ACG and the emergency status and local situations here?
Yeah, so, as the surge was getting worse in the ICU and we were shifting some, volunteer residents into the ICU, and then, there was also some residents moonlighting to help out on weekends. We, in the GMUC pandemic subcommittee, have been looking every time we meet really at ACGME emergency status and whether we should go on it again. For those of you who try to wipe as much of this out of your memory as possible, over the summertime, we did go on emergency status for a total of 60 days. If we were to go on it again at the third stage level, there are some increased requirements, the majority of which we now do meet, except for the final requirement, which is that over 50% of your trainee pool has been shifted to care for COVID patients. I think if we needed to go on emergency status, that's something we probably could explain away. But, right now it sounds like our number, maybe we have, hit our plateau and are beginning to downtrend. So we will discuss that again, actually, at our meeting at 1 o'clock. But, fingers crossed, maybe the worst of the holiday surge on surge is over.
Yeah, let's hope. Okay, Yad, you want to update us on research focused on COVID-19 and what's going on?
Yes, I will try to keep it brief. I know you heard this before. So currently, I will focus on the trial that are active now. I will look for, I will kind of categorize it as inpatient and outpatient. So Blue Coral is a very important trial, and they really are looking at us because this trial, although it is non-interventional, is looking at the socioeconomic aspects of underserved area, and they really want us to be to enroll. We have enrolled so far 39 patients in this trial. It involved collection of a lot of biomarkers and a baseline and follow-up with post-COVID. Act 4, we just were activated last week. Haven't enrolled any patient. This is open label remdesivir and the 2 dexamethasone and baricitinib. Now, as a background, Act 2 was for baricitinib that showed mortality benefit, and we all know about dexamethasone. No one have compared these head to head yet, and this trial was designed to answer that. We are part of the whole UCSF family, but for the sake of this trial, we are a standalone center for regulatory purposes. And the other trial that is very active here is Active 3. And although they sound the same, but this is through Beryl Network, this is a neutralizing antibody trials that we have enrolled 17 patients so far in. This is an infusion. The trial itself is a platform for many antibodies as they are coming. This is the 3rd generation of antibodies. It is a little bit complicated and hard to understand for patients, so that's why we have a little over 50% denial rate. What essentially 3 arms go simultaneously. 1 is placebo and 1 antibody number 1, which is 1 infusion, but the antibody number 2 is 2 back-to-back infusions. And we have infused 17 patients so far, and no major side effects. There have been some side effects reported in other centers, such as anaphylaxis. This study requires a physician to be at the bedside during the infusion, and I have been for the whole 17. Now, we also started our stem cell research. By the way, also Active 3, we enrolled the very first patient in this version 2 all over the world. And this is one of 4 trials in this institution that we enrolled the very first patient. The other one is the stem cell. We have enrolled 2 patients so far, and both have done well and back at home. This is a stem cell that is designed to work for COVID. Now, Dr. Fayed has been busy enrolling with his brexanolone study with SAGE. This is brexanolone is infused as a sedative and anti-inflammatory for people who are intubated from COVID, and he has enrolled 8 patients. And also this trial, this center enrolled the very first patient in this trial anywhere else in the world. And coming inpatient trial are very close to start. We talked about the active 4, which we are already, we're already active, but we haven't enrolled any patient yet. And the EB05 that Dr. Fayed is about to start probably next week. It is also anti-inflammatory, and it works for intubated patient. We have also a new agent called siricimab that mimics the tocilizumab, but targets IL-6 itself. And this is also targeting people who are advanced in the disease. We have paucity of trials in people who are critically ill and advanced in their disease, and we couldn't offer them. Hopefully next week we will be able to offer them these options. Now, this trial is still in the pipeline, and I always like to keep something that is 2-3 months away, because we always are behind in our regulatory. SHERP trial, this is for outpatient. So now for all outpatient, Dr. Fayed has enrolled 13 patients in this trial, and this is in collaboration with the UCSF main campus. And it is very demanding trial, I know for sure, because I myself participated as a volunteer in that trial, and it has a lot of blood draw. And the RAMIC trial, led by emergency department Dr. Shinok, also is actively enrolling. I honestly don't know the most recent number, but I know I have seen many patients in the floor after they got enrolled. And I know that we are looking at the point of care testing versus PCR. More upcoming trials. Also, Dr. Opardija with Dr. Fayed is looking at the favipiravir, and it is about to start probably within a month or less. DISCO trial that looking at disulfiram in collaboration with the UCSF main campus. Also, Dr. Fayed is about to start this. This is also outpatient trial. And also we're very excited to that we were one of very few centers that were approved for by Gilead for outpatient remdesivir. This is only 3 instead of 5 doses. The first dose is 200 milligrams, the usual, but the 2 other doses can be done at home. But the first one has to be done as an infusion center or emergency department. This is supposed to reduce the rate of hospitalization by 10-15%, and targets only high-risk patients who are being discharged home or already went home. We can call them back and start this. And we are at the final stages of regulatory. And those are the closed trial. I'm not going to mention them here, but some of them are done through Petalwood network, and some of them directly by the investigators. APL9 was also a phase 1 trial that also was done here, and we enrolled only 2 patients, but the total number of targeted patients were only 60, and the trial already closed a couple weeks ago. This is the team, because we enrolled the very first active 3 patients in the whole world. They sent us what they called chocolate pizza. There is such a thing, and the team here is to celebrate that. This is sent from Denmark, especially. It was supposed to arrive before Christmas, but we didn't see it until after the new year. I will stop here, and I'll take question now or at the end.
Okay, you may have more volunteers to help run studies if they're going to get a chocolate pizza, I'm thinking. Kenny's saying, yeah, already gone.
Let me supplement Dr. Almasri's presentation a little bit. From the IRB point of view, we last week looked at what our activity has been, and we actually have had 45 different studies, either past, present, or future, that the committee has looked at, and Dr. Almasri and Fayed, et cetera, are foremost in the interventional group, but there are a lot of other studies going on by other investigators as well. And took 5 pages, the list was 5 pages long with 45 different studies that have been proposed. So
And our
lots of activity.
Sorry, and our staff and their cry for help have estimated that in the last 3 months or so, we have been enrolling in each month, we have been enrolling what we have done in a year before COVID time. So hopefully, I mean, we're using this data to hopefully get more help, more coordinators, and this is for another talk, because we're trying to go over the hiring freeze and hire more people to help with these trials.
Great, thanks very much. Kenny, you want to talk a little bit about Mobile Heal, but then maybe you could also transition to some of the undergraduate issues and address the questions that Dr. Asimi sent us this morning.
Sure. Let me actually just start with the student stuff and the UME thing. So, you know, obviously with the crisis that happened with the ICU that was going around the community as well, there was also multiple cases. We had our first couple students that were both lots of exposures, but also first couple students that were actually COVID positive. So we made a decision for a safe learning environment to temporarily suspend outside rotations. And that was decided on in mid-December we would allow the students that were currently already in place to continue, as well as our core students at UCSF and Davis who are giving all their clinical rotations, like their required clinical rotations here. But we suspended for essentially 2 months right now any outside rotations. We also got authorizations to add the medical students into the vaccination list so they could get vaccinated. We got a request from pharmacy in order to see if the UCSF pharmacy students would have access to vaccinations here. I just sent that email on Friday, I believe, to Judy Binnerman, and she just waiting for a response for an okay. But I have 33 UCSF pharmacy students that many of them are requesting to get vaccinated and are here for the year. There was some concern with student vaccinations related to whether they were here long enough, if there are rotations, that they can make sure that they ensure they get their complete course and get their second dose 21 days later for the Pfizer, for example. There's a few little things, but really we're talking about students that are here for 6 months, a year longer. So not really concerned for the vast 90% of it. So we are watching the numbers closely and we'll consider reopening once we know that the ICU numbers are coming down and kind of staying down before we resume on the outside rotations. I'm happy to answer questions about students, but I want to be brief so I can make sure we answer questions at the end. To address Mobile Heal, the big news in the last month since the last meeting is we've moved sites. So at our old site, we were down at Firm, which is a wonderful location, but it's a very small location. So we had a 2-mile car line every day, and we were having traffic backed up to the entrance off the highway. And so police were basically making regular visits to us to clear out. So we have made the move right before Christmas to the UC Merced building. For those who are unfamiliar, that's actually right across from Fashion Fair. So now the parking lot's about 10 times larger so that we don't have a 2-mile long line. We also have made that a successful switch in the last 2 months to the new state-run lab, which is a Perkin-Elmer lab, as Jeff Thomas was mentioning, that they purchased themselves. It's a Perkin-Elmer run and operated lab system, but they have the capacity to do 100,000 tests a day. So the good news is when we started with them a month ago, our testing return rate was taking about 72 hours to get a result when we started. And now they're down to under 24 hours. So the second they get and we're sending them lots of tests. And so our response time is now from test to, from time you swab to get results is under 48 hours. And so our biggest holdup now is actually shipment and getting it to Valencia in Southern California. It's especially on weekends. We have increased our testing capacity where we were stuck at around 200 tests for a long time to now we've broken 430 tests a day. But we are also now not turning away those. We have the same 400 some people coming by, but now we used to turn away half of them. And that was a real problem. And people were piling up hours beforehand. And now I look out the window and we have essentially no line, and we're still testing 300 to 400 people. So we're not turning people away except at the very end of the day. So that's good. Our capacity has really caught up, and that part is going well. And right now we're changing resources with with the city and our CBOs to gearing up so that we can deploy the vaccine. So our plan is to prepare and apply to handle both Pfizer and Moderna vaccines. So that's different than most outpatient clinics that are only doing Moderna. So we are looking at being able to handle, so we can diversify our supply chain, make sure that we have enough access to get it to people out there. So a lot of different options for that. And hopefully, knock on wood, we'll have all the regulatory stuff done just by the end of the month, hopefully. Maybe I'm too optimistic on that. I can go into lots more detail about that, but I think it's better to just go the overview, and I can answer questions at the end. Of note, our positivity rate, our 7-day moving average is roughly 33%, so it certainly hasn't gone down. So 1 in 3 people get tested are positive. So that's certainly not good. I'm glad that the ICU numbers are down. We haven't seen that reflected in the community testing rate yet.
Okay, thanks, Kenny. And speaking of vaccines, Alan, you want to talk about the status of the vaccinations and what you know about what's coming next, if anything?
Right. A lot of information. I'll try to be brief. So remember, it was December 11th that the Pfizer vaccine got the emergency use. And the following week, Fresno County received about 7,800 doses, half of those going to CMC. And CMC has decided to stay with the Pfizer vaccine, at least through this initial period. They started delivering vaccine on December 18th in a trial of 50 patients. And from the 21st forward, nearly every day, alternating sites between CRMC and CMC, doing more than 500 shots in a day's period of time. So as of January 6th, over 4,400 doses were given, primarily first doses, of course. And for some of the numbers, 618 of those were physicians. You know, many of those are our 259 physicians, but it's hard to tell which is which in their registries. However, for residents, we have had 259 residents get their first shots, and that's 78% of our residents. Medical students did have some fallout as to they were to be included, but wound up being left out. So we've been doing a bit of a job of whack-a-mole, trying to get people back in the list. I know that Lori Weichenthal has been receiving a lot of information. Kenny's also been pitching in, but Judy and Tom through the hospital have been accepting the list, adding people in, getting that taken care of. Of interest, there has only been one case of anaphylaxis, and that person will not be receiving a second dose. And since then, the hospital, along with the county, has opened up the 1A status to then pretty much everybody that's taking care of patients. And so the UCOE office staffs will be able to get a vaccine through community hospitals. At the same time, Sante Health has also opened up and has capacity. They are delivering vaccines to Sierra Pacific Orthopedic, and that's the Moderna vaccine. If I understand correctly, by some patient reports, the VAMC is also starting to deliver vaccine. The UCOE offices have applied for capacity to have the vaccines, but we are still in a waiting phase. I'll take questions.
Any conversation at all at the county level or any other level about when phase 1B and phase 1C might be coming?
You know, this is all of this is week by week. These changes are week by week, and as of last week, I believe is the last time I had contact with Rice, and I have not heard any update as to exactly when 1B is rolling out. Having stated that, though, I do know that some of the first responders in Fresno County have started to receive the vaccine, so technically they are easing into the 1B as we speak.
County put out a statement on Thursday night, Friday morning, and they said that they were allowing phase 1B tier 1 to be included for extra vaccines. That was the difference we're talking about policy-wise, where they want vaccines in arms, so they were allowing non-healthcare workers that fit into that, which for those that aren't aware, the phase 1B tier 1 is age over 75 and frontline workers, which include educators, first responders, stuff like that. So so they are, as of 4 days ago, 72 hours ago now, it's now authorized at the county level.
Starting to
Great.
ease into
Thank you.
1B.
Yeah.
Okay,
Mhm.
great.
And there's also, for anybody interested, a county-wide clinic at the Fresno Fairgrounds this week. You can go to Fresno County Department of Public Health, register online. I know that there's been quite a few healthcare providers, MAs, office staff, folks that are involved in the healthcare industry that have kind of fallen through the cracks as far as being able to identify with an organization that has access to the vaccine. But basically, if you have a You know, if you're identified as a healthcare provider, your ID, there's a couple questions you have to answer. That's a great way for, you know, those that are interested to gain access to vaccines that can't do the conventional Sante or CMC route.
Great. I'm just looking at that. So Joyce has a comment on chat that Dr. Vora told her at the end of last week that they expect to be moving to expanding vaccines for seniors next Monday. So looks like it just continues to roll. Tiffany, do you just want to briefly talk about what our screening experiences have been and about the dashboard that you're working with others to get up on our website?
Yes, absolutely. With regards to the dashboard, UCSF Fresno, we're going to be putting together a quick at a glance dashboard that shows all of the cases that we have had since we've been tracking, which is from the very beginning, since March, as well as active cases. So for example, for right now, active cases, we have 4 residents, 2 staff members, 5 faculty, and 1 student. When we use the term active cases, those are individuals who have tested positive and we have yet to either receive a clearance letter from main campus occupational health or clearance from CCFMG that they are safe to return to work. If you are having issues getting your clearance letter, which I understand many have, please reach out to me, email me, and I can see what I can do to try and get to the right people. They are inundated and they're missing them. And it doesn't help you out at all, but I want to be a resource and help facilitate that as fast as we can. The dashboard will be updated and will be somewhere on our COVID resource page. I'm not exactly sure where yet, but we will also be sending out an email every week, likely on Tuesdays, that have the dashboard that'll show the current cases and those that have cleared.
Great. I just want to remind everybody that currently we have in place for UCSF faculty, residents, and fellows and students the ability to get testing done if they've traveled. In fact, the requirement to get testing done if they've traveled outside the 4-county area, but also testing at request as frequently as once every 7 days. And UCSF reached out to me towards the end of last week and said, would it be helpful given our numbers to increase that to every 3rd day if people request it? And the more that I read about the age population that we're dealing with and some of the military studies, the frequency with which we see asymptomatic or pre-symptomatic infections in that age group is incredibly high, 75 to 90%. So I think I'll be asking this afternoon to go ahead and get permission from them to do that. And then what we'll need to do is to change our screening tool to allow people to do that at their request. And I would encourage anybody that wants to get tested to get tested. Okay. All right. With that, let's open it up for questions. Maybe Kenny, I can start with some of the questions that Mitra Simi sent us. Do you want to update everybody about what the status is with students coming back into the clinical environment for UCSF for the med school?
So I don't want to speak for pharmacy because the pharmacy policy was slightly different than ours because it was because that was done with the hospital's decision to go all remote for their pharmacy school for their pharmacy teachings. So, but I'll speak for the School of Medicine is what we're doing is basically looking at midpoint. So basically in the middle of the month, like January 15th by Friday, we're looking at our numbers to determine whether we can resume outside away rotations for the next month. So if we see a significant trend that we see we're moving in the right direction, we can open it back up to February. My guess based on what we're at is even if we're moving in the right direction, we'll probably be closed for February and we'll resume away rotations and outside rotations in March. That's my best guess, unless something miraculously happens over there. UCSF policy on the rotations is negotiated between the CMC and the School of Pharmacy, so I don't want to comment on that, but there was a comment on the testing of students. And as I mentioned, we are no longer capacity constrained, so we're happy to do testing, asymptomatic, symptomatic of anybody, including students, faculty, residents. And like I said, our PCR turnaround times have improved significantly. So as far as that, we're happy to be the testing center for all the staff now. And we couldn't say that for sure before because of our constraints on testing.
And those students, UCSF pharmacy students, could also get testing through the testing that's available in the UCSF Fresno building. I just want to go back to your medical students, though. However, your F2 students are in the clinical environment, right, Kenny?
That is correct. So current core clinical the quote unquote third and fourth year medical students that are Davis and UCSF here completing their required core clerkships are still on rotation. So you'll still see some students, they're just like half of them are gone, the away, basically outside students, but we still have the core students here rotating. And that's for them filling out their actual graduation requirements, as opposed to doing sub-Is and electives to try to, check out for residency. So it's a way to limit it, but still allow students to make sure that they still can graduate on time.
Great. And then I think we addressed the immunization, and that is basically, Alan, you said we're trying to close the loop on getting everybody the invitations to be able to get that. So pharmacy students and medical students could get vaccination, correct?
That is correct. And Kenny's been helping out with that quite a bit. There was email communication over the weekend still.
Great. Okay. All right. At that, open it up for other questions. Tiffany, do we have other questions?
We do. So the first question I see is, any idea when caretaker family members will have access to the vaccine?
I think it's going to depend upon what tier they fit into from the CDC and the Department of Health. Is that right, Alan?
I would think so. And actually, there's going to be something very interesting because Joe Biden said a couple of interesting things about the vaccines. First statement was it's going to take 2 years. Second statement, I've actually asked Kenny about and also Rice about, is that he may open up the vaccine to expand as quickly as possible by limiting second dose. That is, everybody gets a first dose and then we come back and follow up second dose. So some of that in the next couple of weeks may be changing pretty quickly. And there's interesting, I mean, there's rationale that may work. We just don't know how well it will work.
And are you going to discuss the PREVENT study by Dr. Shinak that will be enrolling CMC and UCSF Fresno staff that will get the vaccine?
I don't know if this was meant for the study itself or the vaccine, but I know I have been talking with Dr. Shinak, and yeah, this study is observational, so hopefully we'll have easier time to get it approved. But I will give you an update with the next one because yeah, I don't have data to discuss.
Thank you. And could you repeat who to contact for vaccination at Fairgrounds?
I think it came out, you can go to the Fresno County Department of Public Health under vaccines. They have updates as to what's happening. It also is very useful because they will update that site to, it has all the tiers listed. And if you go on it today, the current resources for the tiers that are included are listed there. So it's a good place to go.
Thank you. Do we have a roadmap for resuming in-person educational sessions for physicians who have been vaccinated?
So Lori, any conversations about that at the DIO levels?
There has not been. I don't know if many of you probably don't know, but obviously Southern California has been hit as hard as we have. So they've really been focusing on just taking care of patients, and both UCI and UCLA went on emergency status with the ACGME over the weekend. So there really hasn't been a lot of discussion about this. Again, right now, officially UCSF is, on hold for all in-person events or meetings until the end of June. My guess is that we're going to need to hear something from the CDC that really shows that the vaccine works over a longer period of time than the initial study period of just 2 months before any of the UC systems are going to be willing to say, okay, we believe in the vaccine, and if enough of your people are vaccinated, we'll start moving to in-person learning again. But that's just my sense. I have not actually had that discussion. So something that hopefully in the next few weeks we can start talking more about.
And will the daily screening website be updated to account for people who have symptoms related to receiving the vaccine? I can partially answer this, at least on the UCSF Fresno side. We've not received any guidance from main campus on updating our screening tool to include that at this point. I don't know about CMC in their screening tool.
So Jeff, do you have an exclusion that says if people come in and they've got a fever, but they got their vaccine yesterday, that they can still come into work?
Yeah, I don't want to comment. I think that they have tightened up the actual symptoms, meaning that if you have it, it points more towards a respiratory focus, but I don't want to go on record. I think we amended our screening tool, but I can't be specific as to how.
Okay.
I think there are a lot of symptoms that are tolerated in that regard, unless they're respiratory symptoms, and that's pretty exclusionary. And it's pretty clear from the reports that people who have had reactions have not had respiratory symptoms. So that's been one of the major criteria that we use to determine whether they should work or not.
Okay, so fatigue, myalgias, low-grade fever, all of those things won't disqualify people if they've just gotten a vaccine?
It will not.
Okay.
I do want to bring up that we did have an individual who received their vaccine and then a few days later did test positive for COVID.
Yeah.
So, you know,
It's
to
gonna
still
happen.
that
Yeah.
it still happens,
Yeah,
that it
it's good.
doesn't, you know, doesn't it?
There's no cause and effect there at all.
No, I don't think that's what she's suggesting, but yeah, important for people to know that this is not a live virus or an infective agent that's being injected. So,
Okay. Any chance we can get a more user-friendly screening tool for UCSF?
so I know what this question relates to, and it relates to pre-filling out some of your answers. And actually, we talked to main campus about that. And what they found was that they were getting symptomatic people slipping through the screening because they weren't taking the time to realize they had to change the answers to their questions. And their informaticists were writing that up as a study to suggest that you have to be very careful about pre-filling out and assuming that people are going to take the time to correct answers from a previous day. So they've strongly discouraged that on our side.
Thank you. Any updates on travel policy, domestic and international, for residents? What are the quarantine time requirements, if any, for asymptomatic clinical staff? What testing is needed? I can answer at least, so really both, but for international, for UCSF, it's a mandatory 14-day quarantine from our building. Now, CRMC, it has been my understanding that they are clearing you to work, but I'm not clear on that. You'd have to, call employee health to see if you're cleared, but at least for the UCSF Fresno building, it is a quarantine for 14 days. And then as far as domestic travel, that's where the asymptomatic testing comes into play with our color testing kits.
How about rotations from outside residents who would like to come to UCSF Fresno for rotation? Is there still a hold on those? And the answer is yes. As Kenny said, they're looking at that on a monthly basis to see what the incidence is in the community. Right, Kenny? Got it.
For residents, I want to speak for students, but yes, for residents.
Oh, that's, yeah.
That's a question for residents. That's why I didn't answer it.
Yeah, I don't, you're right. So Lori, policy right now is all of UC is not allowing outside resident rotations, right?
Correct. The only time they're allowing it is if it's a required rotation that's not offered at their home institution, that can be offered at another local UC. So for example, a resident at UC Riverside who needed a required rotation that they couldn't get there would be allowed to go to UCLA or UC Irvine. But otherwise, all away rotations for residents are on hold.
When will 1B patients followed by East Plaza physicians be eligible for vaccine at East Plaza?
Alan?
I was actually just typing a response to that. So it one, we have to the vaccine, and then once we do, and it looks like January 18th will be the day we'll be able to administer. You know, some of the patients, if there are primary patients, you know, they will be kind of high on our list, and we'll be contacting those that are 75 and above. And then there will be others that come to our offices who may also have other sources, another primary care office, for example. So we'll have to work through those because it will cost us in staff time.
Is there a big difference in the two vaccines? Is one better than the other? Dr. Bond responded to this, but I'll let you want to read it off.
Sure. I mean, I'm just one opinion as a physician, but I think there are differences in the handling for sure. But if you look at side effect and efficacy profile, they're actually very similar, and I feel that both are safe and effective. I'm sure there are much more educated voices that will comment on that. But
Bob, you want to weigh in?
Yeah, I think that's basically the story. The Moderna vaccine is a lot easier to handle, but I think the side effects and the effectiveness is pretty much the same.
Okay. And planning to travel in July 2021, will the travel policy still be in effect then? And I'm not sure if they're asking as far as if we'll still have asymptomatic color testing or the international travel policy, but the at this point, I believe the asymptomatic color testing was supposed to end January 15th. I don't know if that's going to extend or not, but I mean, I have no information from main campus that they're stopping any of the travel guidelines. So I don't think we can, you know, speak to July 2021 at this point. I think it would be wonderful if all of this went away and there were no travel policies, but at this point, I see them still moving forward.
And if you would have asked the same question last February about the upcoming July, we probably would have said, oh, the summer months, we'll be out of this by then, and look where we're at. So
yeah, I think you have to assume going forward for probably 12 to 18 months that things probably won't change a great deal.
buy trip insurance.
Yep. I mean, as Alan talked about, even the incoming Biden presidency is suggesting it's going to take 2 years to get everybody vaccinated that needs to be vaccinated. So I think the reality is settling in that this is a bigger task than it may have assumed at first. And let's see, we just got another question. Would asymptomatic COVID testing by color be extended beyond January 15th? I don't know that there's any end date on the request for asymptomatic testing. Really, the dates that were put in there were to try to reflect anticipated travel around the Christmas and New Year's holidays, which was mandatory if you were coming into a UCSF building that you be tested if you'd traveled. For right now, we still allow testing at request for anyone with no other reason than they'd just like to be tested.
And I have no other questions at this time. At least I don't think. Oh, if I missed one, let me know.
No, Kenny just said that we're starting to get some of the fallout of what happened in Congress on Wednesday with, I don't know if people saw, but the physician, Capitol Hill physician, informed Congress members that they had been in a potential exposure situation when they were sheltering during the rioting at the Capitol. So they all of course scattered to go back home, and then now they're going to need to be tested. So any other questions?
One caution, testing with the antigen is unreliable.
Yep, we're not doing it anymore.
Yeah, I think anybody that's been using some of the antigen testing sites should trust the results that are coming back from those.
Clarify, we never did antigen only testing. We always antigened with the PCR, and we stopped it in the general public. We still do it in some settings. The biggest one is the unsheltered community. So in our homeless community, we're trying to find positives right away because of risk of not finding them 2 days later when we get the PCR back. We're still sending PCRs on all of our antigens and only using quicks on those patients.
Good.
Yeah, that seems reasonable, Kenny. Any other questions? Okay, well, once again, thanks everybody for their participation and their expertise. Have a great day.
Thank you all.
Thank you.
Bye.